My disclosure is that I'm an unwavering advocate for evidence-based medicine, and thereby, by definition, a staunch opponent of pushing the envelope. Can you all see my screen? I just want to make sure it works. I'm not very talented technically.
Yeah, it's showing fine.
Fantastic, thank you. So I just
We
want to.
can also mute you whenever we want to, I think.
I know you can. Which part of Lord of the Rings is that? The power of muting.
Go for it.
Yes, sir. So why evidence-based medicine? Why wouldn't we just push the envelope and continue with anecdotal practice as we feel is best, and we've always done it that way, or experiment new stuff that has been untested and unproven? And simply stated, it's just reducing the variability in care. And I guess if I'm not certain what to do and ask myself, what would the patient want? I think that sounds like a good thing. I want to be treated by the best practice, evidence-based, proven standards, and I don't want to be part of the learning curve of a young surgeon or a more experienced surgeon who's trying new, unproven experimental techniques. I guess that everyone on this conference would agree with that. So let's spend a minute looking at this complex slide on the levels of evidence. If we start at the very bottom, animal and laboratory bench studies are considered grade 5 evidence. And so there's not even humans involved because we just don't know how to extrapolate the knowledge from a broken femur in a mouse or a goat onto humans. And then comes level 3 and 4, which are the most frequent type of studies you see when you go through some of the orthopedic journals, Journal of Orthopedic Trauma, Journal of Trauma and Acute Care Surgery, because it's easy. It's easy to report a case report of a patient who did most frequently excellent under your care, or a series of a few cases, or a retrospective observational cohort study or case control study, which are easy because you just go back and look at some cases you did, but they're also flawed because there's a significant risk of selection bias, and frequently the outcome had already been determined at the time when you pull your data and analyze your data. Level 2 prospective cohort studies are a little more sophisticated because the outcome has not yet been determined, but obviously the holy grail are randomized controlled trials, RCTs. They're considered level 1 evidence. And there's some pitfalls with that because there's a lot of papers submitted these days that claim to be an RCT. And if you look at the methodology, they're really not. And I'm going to spend some time talking about that. And when you do a meta-analysis or systematic review of the published literature, then all the RCTs, which are then considered secondary studies, studies of published studies, will tell you what the best practice is on how we should treat our patients. And those will ultimately be included in clinical practice guidelines and endorsed by societies. And then ultimately when that happens, it's really hard to deviate from that standard of care, and how to explain to the judge in the court of law why my anecdotal practice deviating from those guidelines is better for the patient. And I better have some really strong and compelling arguments to support that. So how do we do in orthopedics? Actually, pretty well. If you look at some of those studies published recently, this one in CORE, have levels of evidence improve the quality of orthopedic research. And we see that level 1 and level 2 evidence publications have significantly increased in the past decade. And a paper in the Journal of Orthopedic Trauma showed the same, that in the past few years, it looks like level 1 studies have significantly increased, and then poor quality level 4 and 5 studies less. So I guess that's a good thing. So if that's the case, we should actually all be happy. But are there risks associated with evidence-based medicine? And I guess if there weren't, Jeff would not have invited me to discuss this here today. So the first and the most compelling is that you look at all these meta-analyses and then the guidelines endorsed by societies with the notion of garbage in, garbage out. They're all ultimately based on the quality of the single published study out there. And if that study design is crappy or flawed or biased, but published, and let's be honest, ultimately in this day and age, everything gets published. It gets rejected by one journal, you keep resubmitting until it's published. And once it's published, let's assume I claim my study is a randomized controlled trial, but I really did a certain randomized trial where I would treat every P-long fracture that comes on my watch with a ring fixator, and Jeff Smith would be the other surgeon who does an ORIF on all of those, and we compare the data and draw conclusions. That is not a randomized study, but by the fact that we got it published now, folks think that's level 1 evidence when it's not. So garbage in, garbage out. The meta-analysis can be no better than the single common denominator of the quality of the worst quality study assessed. And then there's this risk of salami slicing. And I was born and raised and trained in Europe. And when I was at the Charité Medical Center in Berlin, in Germany, that the notion is publish or perish. And the easiest way of publishing a lot of papers is to take one set of data and publish it many times. And there's 2 ways of doing that. One is, if you're honest about it, at least you just publish different sets or subsets of that data. If you're dishonest, you publish so-called redundant publications. So I could, for example, choose, I'm bilingual, so I could choose to publish one original study in a German peer-reviewed journal and the second one in English language. I hope that nobody would recognize that because folks typically don't read both. And it would be the exact same study with with some subtle minor changes. And what is the risk of redundant publications? First of all, they inflate the available literature. We are already overwhelmed with the tens of thousands of new articles published every year. And it skews the evidence because we assume that the number of articles reflect the number of new insights. And last but not least, the distortion of available scientific data will overestimate the therapeutic effect. So if I have 3 papers out of the same set of data published, it looks like the evidence from those studies are much more compelling when in truth, it should only be one single publication. This is a cool graph that I pulled out of The Economist, and I will briefly explain what that means. If you have a hypothesis, and there's 1,000 tests in the left panel, and we know that 100 of these are true because we have that magic notion of knowing which hypothesis is true. So 100 of 1,000 are true. So now if you have a false positive rate of 5%, you would add 5% of the other 900, which is 45 that are false positive. And if power of the study is 0.8, you would have 20 false negatives. Those are the red ones. So now you pull out the new true, which inflates the truth by 45 false positives. That's one problem. And the second problem is it completely neglects the insights from the false negative or the irrelevant studies. And that's a common flaw when we do meta-analysis of the published literature. And then last but not least, as you know, we're all biased. We're all inherently biased. So we're certainly biased when we publish papers. And I'm the editor of a peer-reviewed journal, and I'm probably biased in what I accept and publish in our journal as well. So many years ago, Eric Hasenböhler, who is a Swiss fellow like me, who was looking for an opportunity to be an attending orthopedic trauma surgeon, had a gap year and wanted to do some research in our lab. So I've had to figure a way to keep him busy. And I thought it'd be a great idea to have him review 30,000 articles just to keep him busy around the clock in those journals that we selected that you see in the left column. and analyzed them for journals that publish positive data versus negative data and significant versus insignificant data. So of the 30,000 articles, he pulled more than 16,000 original articles and pulled the full article on those. So I really kept him busy. He still hates me for that. He's currently a successful surgeon at Johns Hopkins. And this is one graph that shows some of the results. So the majority of articles published in all these journals show positive data. Very few show negative or neutral data that are equivalent. And if we look at significance, they're all 91% are statistically significant for whatever that means. So if I conduct a study and show inferiority or lack of superiority of a certain type of procedure over the other, it's very likely not going to be published, even though if I was the patient, I would want to know that that treatment does not work, especially if there's a lot of studies out there that would show that. And I applaud the editors of the Journal of Negative Data and the Journal of Irreproducible Data, because those are significant insights into the science. And so last but not least, statistical significance get published. And all the journals I read and all the submissions I review for our journal, most frequently as a reviewer, I ask the question, so what? The P is less than 0.05. By the way, you guys may have noticed that frequently the P is less than 0.0001, which I wonder what that means. Maybe the authors just think it has a higher chance of acceptance. And most of these statistical analyses are flawed. But the question is, what is the clinical relevance? How does it matter to the patient? And let me pick one example of completely failed evidence-based medicine that probably harmed and even killed tens of thousands of patients on our watch for many years. And so I'm a trauma surgeon and a spine trauma surgeon. So this is a screenshot from the ATLS manual, 7th edition from 2004. And at that time, the NASCIS trial, that's the National Acute Spinal Cord Injury Study 2 and 3, showed that if a patient has blunt spinal cord injury and you treat them within the first 8 hours, you should give high dose methylprednisolone. And I remember how proud I was, and as an ATLS instructor and spine surgeon and resident at the time, we knew exactly it's 30 milligram per kilo loading dose, typically 2-gram loading dose, and then 5.4 milligram per kilo per hour for 24 hours or 48 hours. And we administered that to all our patients, not knowing that we were causing harm. And if you look at not the most recent, which was published in 2018, but in 2012, the 9th edition of ATLS says at present, there is insufficient evidence to support the routine use of steroids in spinal cord injury. And that's even a politically correct statement because they are actually harmful. So for all these years, if you chose not to treat a patient with steroids, you better explain that well, document it well, and know how to explain it to the judge. So in terms of defensive medicine, when in doubt, we will give steroids. And there's an even more provocative paper that truly suggests that tens of thousands of patients around the globe have died from immunosuppression, hospital-acquired infections, ventilator-associated pneumonia, and so on. So it's a horrible story of EBM failure. And we owe it to one brilliant mind, Dr. John Hurlburt from Calgary, who just looked at those studies and said, I just don't believe that that stuff is significant. So he took the time to go back to the original database of the NASCIS trial and reanalyzed every single parameter, and he published it. And he, as in this one example of a graph, showed that there's no significant difference. And what was perceived as a significant improvement in motor function would, for example, only apply to the right upper extremity, but not to the left or the lower extremity. So it was statistically significant because of the sheer volume of patients included, but it was not clinically relevant. It didn't mean a thing for the patient, and we actually harmed them by treating them with steroids. And this table from the Herber paper, it shows, yes, the study was well designed, both the NASCIS 2 and 3. Yes, well executed. Compelling data, no. Statistical significant with appropriate tests, no. And then the clinical relevance and the reproducibility of results, no. It's an amazing paper and a brilliant mind. I recommend everyone to read that because it kind of forces us to reassess when we, as robots, apply evidence-based medicine, not even knowing that we're not just not healing our patients, but we're truly harming our patients. That's a reason, Jeff, to push the envelope. I love this quote from Arnold Relman, who is the late editor-in-chief of the New England Journal, who said, "There are many forces coming together to harm or even kill the patient. Their physician should not be one of them." So let's look at some limitations of evidence-based medicine. I just love these type of studies. In the late 90s, there was a paper that showed that remote prayer
Phil, I'll have you wrap up shortly.
I'm sorry. Okay, I'll keep it
going,
short.
but just, yep. I don't know how many more slides you got. Keep going.
Thank you, sir. I'll keep it short. But remote prayer in randomized controlled trials heals heart attacks and patients with bloodstream infections. And the studies are well designed, and there is no way that you could criticize that they're level 1 studies. The question is, does that really work? And this one was even retroactive, so they prayed after the fact and showed a significant difference. And of course, the notion that parachutes are only empirically safe when jumping out of an airplane because there's no level 1 evidence. And yes, people could design animal studies where they're randomized to have or have not the parachute, but then again, those would be just considered level 5 evidence. So let me conclude with a few last slides on this one study, that if you don't believe that a randomized controlled trial, prospective trial has been performed on humans to assess the efficacy of parachutes when jumping out of an airplane, here it is. And I actually love how the introduction states that it's not just that it's not been proven that they're safe, but there's actually a lot of anecdotal reports that show that accidents have happened when using parachutes. So they designed a trial, a true randomized controlled trial on 92 aircraft passengers, of which 23 agreed and were enrolled. And what they showed, and this is the flow diagram, which shows absolute pristine adherence to the consort expectation of randomized controlled trials. And the results show that there's no significant difference if you randomize patients to jump out of a plane with a parachute or just a backpack. However, they say that the lower altitude was not significantly different, and that we should be cautious in extrapolating the insights from this study to higher altitude jumps. And then this is an image from that paper. And so those participants actually jumped out of a stationary airplane with a backpack. And you could say, duh, but I would tell you, how many times do we read papers that says we're not certain if we can automatically extrapolate on a larger cohort or different types of patients, but we still do it on a daily basis. So there's a lot of threats associated with evidence-based medicine, and we have to be extremely careful as reviewers when those submissions come in, and as readers when we extrapolate on how we treat our patients, and certainly as authors and scientists when we design those studies to make sure that they are clinically relevant and not just statistically significant. I hope I didn't go over time, Jeff, and I thank everyone for the opportunity of speaking at this conference, which is actually my favorite conference of the year. So kudos to you, Jeff, for your perseverance and entrepreneurial skills. Thank you.